This case is a patient who was about 68 years old, presented with voice change. Clinic endoscopy showed a suspicious growth in the right vocal cord. The anterior commissure appeared free. The lesion was extending to the anterior commissure. Posteriorly, the lesion was extending up to the vocal process of the arytenoid. On evaluation under anesthesia with the laryngoscope, it was a class 1 exposure and we were able to visualize the lesion in entirety. Since the lesion was a large lesion involving the entire vocal cord, the plan was to do a segmental resection in two parts. We started with the anterior third, third resection or anterior half resection by starting from the anterior commissure area, and the plan was to do a type 2 cordectomy. The incision started with the exposure of the anterior commissure area, encountered a spurter which usually occurs in this area, which was managed with the monopolar suction cautery. You can appreciate the ligament which we look at closely, and there was the thyroarytenoid muscle or the vocalis muscle which appeared free, which was the depth of the resection. Then we did a transtumoral resection, ascertained the depth. Again, the depth of the resection was subligamental, and the vocalis muscle was free, and you can see a clean cut being done with an oncological resection of the anterior part of the resection. Made sure that we got a good subglottic margin. The power was a super pulse continuous free beam with a 2-watt power. That is the anterior part of the resection completed, and then we went ahead with the posterior resection, resection right from the vocal process of the arytenoid and the remnant of the vocal cord lesion. In this situation, it's very important that we cover the cuff of the endotracheal tube with wet neuropathy so that we don't accidentally hit the cuff of the endotracheal tube. Also, when dealing with the posterior third lesion, it is very important, since the endotracheal tube is very in close proximity to the lesion. We need to be very cautious when we are using the laser close to the vocal cord. That is the post resection, a type 2 cordectomy defect. Entire length of the vocal cord, you can see a very clean cut and a very smooth thyroarytenoid muscle, which is very important. When it heals, you have an even surface and a good mucosal wave or mucosal healing happens there, and with good compensation of the normal vocal cord on the opposite side, we get good voice outcomes. The charring of the anterior commissure is because of the cauterization in that area. Thank you.